Introduction. Adrenal disorders represent a group of complex endocrine conditions that can have significant implications for overall health and well-being. Among these, congenital adrenal hyperplasia, CAH, stands out as one of the most commonly encountered disorders, with an estimated prevalence of 1 in 16,000 to 18,000 individuals worldwide. CAH is a group of autosomal recessive disorders characterized by deficiencies in enzymatic activity involved in cortisol synthesis within the adrenal cortex. CAH poses critical challenges in diagnosis, management, and treatment due to its varied clinical presentation and potential for life-threatening complications. In this comprehensive script, we will delve deep into the fascinating world of CAH, exploring genetic mutations, clinical manifestations, pathophysiology, diagnostic tests, treatment options, and the latest research advancements surrounding this disorder. Through a better understanding of CAH, we can improve patient outcomes and enhance our ability to provide personalized care. CAH is predominantly caused by mutations in genes encoding enzymes crucial for cortisol synthesis, such as 21-hydroxylase, 11-beta-hydroxylase, 3-beta-hydroxysteroid dehydrogenase, and others. These mutations can result in a wide range of phenotypic variations, making the classification of CAH into classic and non-classic forms essential for clinical characterization. Understanding the specific genetic mutations associated with CAH is crucial for accurate diagnosis, genetic counseling, and predicting the potential severity of the disorder. This topic will explore in detail the various genetic mutations involved in CAH and their implications in disease presentation and management. Classic CAH represents the severe end of the spectrum, often leading to life-threatening adrenal crises in neonates. This topic explores the clinical presentation, symptoms, and diagnostic strategies for classic CAH. Additionally, non-classic CAH, characterized by a milder phenotype, poses unique challenges in diagnosis due to its variable presentation, subtle symptoms, and potential late onset. Understanding the clinical manifestations of classic and non-classic CAH is pivotal in ensuring timely management, preventing complications, and improving overall patient care. 21-hydroxylase deficiency is responsible for the majority of classic and non-classic CAH cases. It is caused primarily by mutations in the CYP21A2 gene, resulting in impaired cortisol and aldosterone synthesis. This topic will provide an in-depth understanding of the pathophysiology, genetics, and clinical implications of 21-hydroxylase deficiency, highlighting the importance of precise diagnostic modalities and tailored therapeutic interventions. The inability to efficiently convert cortisol precursors into cortisol due to enzymatic deficiencies leads to a cascade of hormonal dysregulation within the adrenal cortex. This topic elucidates the intricate pathophysiological mechanisms that underlie adrenal hyperplasia in CAH, providing insights into the excess androgen production, feedback mechanisms, and potential implications on overall adrenal function. Hyperandrogenemia is a hallmark feature of CAH, causing varying degrees of virilization in affected individuals. Understanding the consequences of androgen excess on the development of secondary sexual characteristics is crucial for comprehensive diagnosis, management, and addressing potential psychosocial implications. This topic explores the effects of androgen excess on both males and females and the potential approaches to mitigate its impact. Accurate diagnosis of CAH relies on a comprehensive evaluation of hormonal profiles and genetic testing. This topic provides an in-depth analysis of the laboratory tests used in diagnosing CAH, including measurement of 17-hydroxyprogesterone, androstenedione, cortisol, and ACTH, among others. An understanding of the interpretive challenges, limitations, and nuances of these tests is crucial in achieving an accurate and timely diagnosis. The management of CAH primarily involves hormone replacement therapy to restore normal adrenal function and prevent adverse sequelae. This topic delves into the intricacies of hormone replacement therapy in CAH, exploring the different pharmacological agents, dosing strategies, monitoring parameters, and potential challenges in achieving optimal hormonal balance. Each individual with CAH exhibits unique clinical characteristics, requiring tailored treatment regimens. This topic emphasizes the significance of individualized approaches in CAH management, encompassing dose adjustments, monitoring parameters, and lifestyle modifications. Strategies to ensure compliance and empower patients in self-care will also be discussed. Adrenal crises are severe and potentially life-threatening events that can occur in individuals with congenital adrenal hyperplasia, CAH. It is essential to promptly recognize and intervene in these situations to prevent further complications. Signs and symptoms of adrenal crises include severe fatigue, dizziness, dehydration, low blood pressure, and electrolyte imbalances. Management algorithms are crucial in guiding healthcare professionals in the appropriate steps to take during an adrenal crisis. These algorithms include protocols for administering emergency medications such as glucocorticoids and mineralocorticoids, monitoring vital signs, and ensuring adequate hydration. Emergency management plans should be established for individuals with CAH, outlining steps to be taken during an adrenal crisis. This includes educating patients and their caregivers on recognizing the signs of an impending crisis and ensuring prompt medical intervention. Preventive strategies play a vital role in minimizing the frequency and severity of adrenal crises. Regular follow-up appointments with an endocrinologist are essential to monitor hormone levels and adjust medication dosages accordingly. Stress management techniques, such as relaxation exercises or therapy, can also help reduce the risk of adrenal crises. In summary, the management of adrenal crises in individuals with CAH requires prompt recognition, intervention, and prevention. Healthcare professionals must familiarize themselves with the signs and symptoms, follow management algorithms, establish emergency management plans, and educate patients on preventive strategies to ensure optimal care and outcomes. CAH can have profound effects on growth and skeletal development in affected individuals. This topic explores the growth patterns, potential growth impairments, and skeletal complications associated with CAH, highlighting the importance of timely diagnosis, appropriate treatment interventions, and multidisciplinary care. Reproductive issues pose unique challenges for individuals with CAH, including concerns related to fertility, pregnancy, and hormonal management. This topic delves into the impact of CAH on reproductive health, exploring fertility preservation options, pregnancy planning, and antenatal care considerations to optimize maternal and fetal outcomes. Ongoing research efforts continue to unravel the complexities of CAH, leading to advancements in diagnostics, treatment modalities, and overall understanding of the disorder. This topic provides an overview of the latest research advancements in CAH, including novel therapeutic targets, genetic editing technologies, and potential breakthroughs on the horizon. In conclusion, CAH represents a complex and heterogeneous group of disorders that require comprehensive understanding and individualized approaches for effective management. Through a detailed exploration of genetic mutations, clinical presentation, pathophysiology, diagnostic tests, treatment options, and cutting-edge research, this script aims to provide medical students with a thorough knowledge base to empower them in the care of individuals with CAH. By utilizing evidence-based strategies, multidisciplinary collaboration, and patient-centered approaches, we can make significant strides in improving the quality of life and long-term outcomes for individuals living with CAH.